Hello, and welcome to another edition of Inside Your Miami Medicine. I'm Henri Ford, the Dean and Chief Academic Officer of the University of Miami Miller School of Medicine, UHealth. Today I'm joined by Dr. Frank Penedo, Sylvester Comprehensive Cancer Center's Associate Director for Cancer Survivorship and Translational Behavioral Sciences. He was recently announced as the Sylvester Dolphins Challenge Cancer Living Proof Endowed Chair in Cancer Survivorship. That is a mouthful because he is such a big deal. So, Dr. Penedo, so glad to have you here. This is going to be a fun conversation. You've held many positions in our organization, dating back to the times as an undergraduate.
Yep.
So tell us a little bit about your course, because you were also a postdoc here, faculty member, and now a leader in our cancer program. Tell us about your journey to all the things you've been able to accomplish and where you stand today as an endowed professor in our university.
Sure. Thank you, Dean Ford. It's a pleasure to be here, and thanks for this opportunity. So, as you said, I started my undergraduate career here at the U many years ago. And when it came time for grad school, I said, well, this is my opportunity to leave Miami, which is my home. But I was so impressed with the programs here in clinical health psychology, which is my PhD in, I decided to stay. Then it came time for a postdoc. I said, now I can go. And I did do 1 year at the University of Pittsburgh for my clinical residency, but I got drawn back into a postdoctoral fellowship funded by the NIH here. And after that, a job opportunity opened up in collaboration with the Sylvester Comprehensive Cancer Center, and I took on that opportunity and stayed at that time here for 12 years.
Okay. But then you came back in 2018. You were recruited. Tell us about that piece and how do we get you back?
So I was recruited to Northwestern University.
Okay.
Where it was one of those opportunities that you couldn't resist, you couldn't turn down. I was younger back then too, so I figured now or never, let me take this on. And I loved Northwestern. I had a great time up there, but I remember in the middle of sitting in my family room, I got a call from Aaron Kovitz telling me, hey, Frank, we have an opportunity for you down here that I think would be of appeal to you. And I said, sure, I've loved being up here, but Miami's my home. I love the U, so tell me about it. And just long story short, I got a write-up of what Dr. Neimer had put together for the NSI designation. I was just so impressed with all the growth and all the development that had taken place in the short time that I was up in Chicago, which was 6 years, that I said, definitely, I'll explore it. And I came for an interview, and then the rest is history. I'm here.
Wonderful. So tell us a little bit about the cancer survivorship and translational behavioral sciences program.
Sure. So there's been a lot of emphasis over the past several decades in cancer survivorship. We have seen an unprecedented...
And why is that?
Well, survival. So we have seen since 1991, survival rates have increased by 30%.
Wow.
I mean, that's a huge increase. And of course, it's a combination of early detection, better treatments, reductions in smoking, which, as you understand, has a big impact on cancer. So the NCI, the NIH, professional organizations have been very focused on, now that people are living longer after a diagnosis of cancer, how do we maintain good quality of life, improve their outcomes?
Because they'll have a lot of challenges, I imagine.
They do. So the survival benefit, unfortunately, does get offset by long-term effects of treatments like radiation, immunotherapies, chemotherapy, that persist 10 to 15 years after treatment. So these are very chronic challenges for our patients. So the NCI developed an Office on Cancer Survivorship. A lot of specific scientific programs and funding mechanisms are specifically geared towards helping the survivors.
Sure. So I imagine that not only do they have other challenges, they could even have recurrent cancer if they're living long. So the quality of life becomes a real issue and how to maintain good health. As
exactly. So it's a combination of challenges, starting with the long-term side effects that they get, including fatigue, cognitive challenges, secondary cancer. So cancer patients and survivors are more likely to develop a second cancer or have a recurrence of the initial cancer, obviously. And then things we don't think about, like financial toxicity.
Wow.
That is
What is that?
So that is a concept that's been around for maybe about 10 years or so, and now we're paying closer attention to it. But cancer care and treatment is one of the leading factors leading to bankruptcy in the United States for many families.
Wow.
So the issue of financial toxicity revolves around the financial challenges that patients and their families have when they have to not only get treated and they may not have all the resources and insurance to cover it, but also how it affects roles at work, inability to return to work, or maybe having to step back a bit.
Wow. A lot of factors that clearly affect the quality of life after cancer. So it's not just enough that we are able to treat cancer now and have long-term survivors, but they also have serious challenges that continue to impact their lives.
Absolutely. Absolutely. And I always say diagnosis and treatment is so important, and we don't undermine that in any way, but we have to also focus on the journey that takes place after that.
Well, I'm so glad you and the team are focused on that. So tell me, you were recently awarded a grant, a $9.8 million grant from the NCI to study the Hispanic, Latino cancer survivorship, to study, Hispanic, Latino cancer survivorship. Yeah. Tell me about that grant. Tell me about the genesis, of the grant, how you decided to attack that particular problem, and why the NCI would give you $10 million to study that.
Yeah, absolutely. So we're very proud that Sylvester and the Miller School of Medicine is the first institution to actually conduct a cohort study on Latino cancer survivors. And to your point of why so much money for a specific population, the cancer experience in Hispanics is quite complex. So if you look at the statistics, Hispanics are about 30% less likely to develop the most common cancers like prostate cancer, breast cancer, and colorectal cancer. But there are greater risk for other cancers like cervical, stomach, and liver cancer. And particularly...
Why is that?
Well, we think it's, again, a combination of factors, primarily limited access to healthcare. So Hispanics are 3 times less likely to have insurance relative to other racial ethnic groups. So that's a main factor. There's also some cultural factors at play, including stigmatization of cancer, where it's still viewed. It's changing, but there's still this negative stigma attached to it as thinking, oh, I did something wrong, or I'm being punished for something. So when you take the lack of insurance, lack of access to care, and some cultural hesitancy that prevents them from talking about screening or risk factors, you put it together and you see these cancers. And Hispanics also, specific to liver cancer, cervical cancer, these are viral cancers that can be prevented, and Hispanics tend to have higher rates of HPV, hepatitis C associated with those cancers.
It's fascinating. So this cancer disparity is related to access, late diagnosis, access, and so forth, and some cultural issues. So how do we begin to address them? How do we begin to attack these disparities to achieve better outcomes?
So that's what the study's about. So we're trying to have a better understanding of what's contributing, at least in the survivorship phase. We're not as focused on the prevention because 9.8 million sounds like a lot, but there's only so much you can do. So we're very focused on the adjustment to the cancer diagnosis, because it's not only that they have more prevalence of those rare cancers I mentioned, but also if you look at after treatment, their quality of life and their symptom burden seems to be greater than for other groups. So we're trying to understand that as well. So in this cohort, we're recruiting 3,000 Hispanics across Miami and San Antonio, and we're assessing a variety of factors: contextual factors like income and access to care, stress factors like general stress or even acculturation and Hispanic specific stress, behavioral factors like diet, exercise, and psychosocial factors like coping, social support, knowledge, and attitudes. And very exciting to us, we're also looking at genetic admixture to look at the variability in the Hispanic community in terms of genetic background. And we're looking at signaling of inflammatory pathways that are related to stress that can contribute to exacerbating symptoms.
So if I understand correctly, so this kind of study, this kind of rigorous analysis has not been done before.
It has not
in the Hispanic Latino population. Why is that? Why did we ignore such a growing population, the largest minority?
Yeah. So almost 19% of the U.S. population, right. 62 million. I think the message traditionally has been, well, when you look at prostate, colorectal, and breast, Hispanics have less incidence and prevalence. So let's focus. In other groups, rightfully so, because it's not like non-Hispanic whites and African Americans are out of the woods in any way. They have very severe outcomes as well. But I think now there's been more interest in the Hispanic community because of the growth that we're seeing in that community.
So clearly this is going to be crucial for developing better outcomes.
Yeah,
and that's what you're hoping this is going to lead to.
Absolutely, and framing messages for management and prevention of cancer.
And so what do you anticipate are going to be the critical factors if you were going to guess? And I know scientists, we form a hypothesis and then we test it. So what is the driving hypothesis behind this?
Yeah.
What you think is going to impact outcome?
Yeah, so we're very focused on modifiable factors.
Okay.
It's hard to modify access to care, income, migration status, and things, factors like that. But what can we change? So as behavioral scientists, we can change attitudes, knowledge, coping behaviors, communication with a healthcare provider. So there's a lot of factors in the model that we're testing that we have developed interventions that have been tested in other contexts that we know help promote better outcomes. So that's our big hypothesis. What are the modifiable factors that matter? And then can we frame an intervention based on those factors that provides from public health messages to very targeted, specific cancer interventions to help these patients?
You mentioned earlier that you're recruiting 3,000 patients for this study. Are they all from South Florida? Are you collaborating with some other institutions?
Yes.
And then tell me which ones and why.
Yeah, so it's a multi-site study. We're the lead institution, but the other institutions, University of Texas Health Science Center in San Antonio. And the reason for that is because, as you know, Dean Ford, the Hispanic community is very diverse.
Sure.
And the Hispanic community in Miami is very different from the rest of the Hispanic communities in the U.S.
That's right.
So we have representation from 15 distinct countries here in Miami. And in a place like Texas.
And there's a fall mostly Central Latin America, Central. Okay, got it.
Yeah. So in Miami, obviously, we're going to be focused on Caribbean, Hispanic, Central, and South American. And in San Antonio, they'll almost be exclusively Mexican Americans, which are 62% of the U.S. Hispanic population. So it makes sense.
Good. But that's fascinating. So this heterogeneity is going to be quite good. And you said you're going to do some genetic linkages and so forth. So with such a diverse Latino population, you'll be able to really pinpoint some of the variables that may be applicable for Central American, Latino, Latinx people. Or this is fascinating. Huh?
Yeah, it's very interesting to us.
Yeah, that's unique. So how are we going to use this data to influence policy and outcomes? What do we do when we find out all this good stuff?
Yeah, that's a great question. So part of the challenge we've had, because this hasn't been done before, we haven't been able to go and impact policy with data. So this data is going to really create the pathway or the framework so that we can start promoting those messages to public health agencies, the CDC, the government, obviously. So that's what we're hoping.
Yeah, so clearly very impactful. So how far along are you now in terms of recruiting?
So we're a year into the study.
Okay.
As you know, recruitment is always our biggest challenge, and the pandemic and other issues get in the way. But we're doing relatively well. We've recruited over 180 participants up to now. We have 6 years to recruit 3,000. A lot of the startup period of the project was working out the logistics, the procedures. So now we're in the field, and we hope to meet our mark.
Fantastic. So as a Cuban American, I'm sure this is particularly important to you. And so tell me about the significance of leading such a study in your role in helping to influence or improve the outcomes for people from your native country and yeah.
Yeah, I'm very honored to have the opportunity to do that. For me, for my family that's been hit by cancer, as many of us have, so it's personal in many ways. And just a little story about the cultural piece. I remember watching with my family some Spanish telenovelas, and this was many years ago, but the villain died because she was a bad person and she died of cancer because God punished her. And that sort of planted a little seed in me saying, what about the good person that gets cancer? And it just comes all the way around into how culture sometimes sends these messages that can be counterproductive to the health of our community. So I'm hoping that we can tease some of that out and come out with very clear messaging that's culturally appropriate for Hispanics.
That's interesting. That's the stigma you talked about. So we talked about the disparity, but the stigma. You get cancer, this is punishment from God. This is part of the whole thing. And so you don't really want to get that diagnosis, that label, because it casts a bad spell on you and your family, potentially.
Yep, exactly.
Well, this is going to be quite enlightening, and it's going to be fantastic when you can present real data saying, no, this is not God punishing you. Thank you. So thank you for that work that you're doing. Let me shift slightly, and let's talk about the wellness check that you have developed. Can you tell us about this pioneering tool to monitor the health of cancer survivors?
Sure. So following models of value-based care, which is, they promote engagement of patients, optimizing technology and optimizing clinical workflows, we embarked in meeting some of the mandates that are set by professional organizations to accredit cancer centers, which require that our patients are monitored on a regular basis for psychosocial distress, symptom burden, practical needs. So the NIH has put quite a bit of an investment behind developing tools that are computer-based, and they use computerized adaptive tests. So the tests are relatively brief. They get calibrated based on the response pattern, and they tap into very specific domains that we know are relevant for cancer patients. So this My Wellness Check tool that we develop here uses the tools developed by the NIH PROMIS, which is a patient-reported outcomes measurement information system, to capture depression and anxiety, to cover distress. They also capture pain, fatigue, and physical functioning, and these five are kind of like the big five concerns or challenges that our cancer patients have. And we also assess practical needs like need for transportation, childcare, financial counseling. And we've embedded that within the EHR and the patient portal. So we can track that remotely right before the patient comes in for a visit.
So how does that work? So my mobile phone, I can just fill in all this information.
Exactly.
And how long does that take? And
so it's through the patient portal. So if you have a MyChart account, you will get prompted if you have an appointment coming in for an ambulatory oncology visit, and it reminds you to complete My Wellness Check. It takes, depending on literacy, speed, and technology knowledge, maybe between 12 and 20 minutes, depending on the patient.
And it's in Spanish also?
In Spanish and English. And we're thinking of a Creole solution for that because the instruments are not validated in Creole, but we want to make sure we reach that community. And one of the major benefits is that because it lives in the electronic health record, if a patient has clinically elevated depression, for example, a real-time best practice alert goes to the social work team. So the social work team knows to intercept that patient when they're coming in. Similarly, if they have elevated fatigue, the best practice alert goes to the medical team. So they can address it.
So you can fill out this questionnaire and then you can diagnose depression.
It's more of a screener. It's a screener. And it's a very well validated screen. So if somebody has what we set a clinical cutoff at moderate or severe, chances are probably that person has
depending on the symptoms that they report on that wellness check, then you can say, high risk for depression, you go see the
social worker,
and then they'll do a more extensive. And how is that important for better outcomes?
Well, so we know that depression and anxiety interfere with adherence to treatment. being able to engage in quality of life activities.
Mm-hmm.
So
Mm-hmm.
eventually that starts collectively impacting
Mm-hmm.
not only the emotional well-being of the patient,
Mm-hmm.
but also their ability to engage with their care.
So how, of all the measures that you are monitoring, um, which one so far looking most promising? Well, first, remind us everything you're looking at, and what looks most promising, or what are you able, which ones have led you to actionable items thus far?
Sure. So we do mental health, depression, anxiety, the physical symptoms.
Okay.
Then we do practical needs like
Mm-hmm.
transportation,
Got it.
childcare.
Mm-hmm.
But we also assess nutrition.
Huh.
And amazingly enough, the biggest concern we get from our patients are nutritional concerns.
Really?
There's a lot of confusion out there. So think about, not even for a cancer patient, just in general,
Mm-hmm.
what to eat, what not to eat, which
Right,
diet,
right.
which herbal supplement is what you want to be taking.
Mm-hmm.
So our cancer patients come in with a lot of questions and a lot of needs
Mm-hmm.
about nutrition. But I would say for us, addressing the depression and anxiety along with the pain, fatigue, and physical functioning
Mm-hmm.
are the more critical ones that we want to address, because traditionally these symptoms have been underreported and undertreated in
Mm-hmm.
oncology.
Mm-hmm.
So having a system in place where we can do that is going to get resolution of those challenges.
Got it. And you don't want to reveal yet which ones most promising.
Well, so I can reveal some findings we have.
Okay.
So we're about to publish in the Journal of Clinical Oncology.
Okay.
That
that's a major
it's
journal.
It's an impact, I think 44. So
it's very impressive.
Yeah, so we're very pleased. The article's in press, and what we're showing is that patients that engage in the system, relative that those do not, so it's almost like a case control study, have less likelihood of ending up in an emergency room visit or an unplanned hospitalization. And those are two big challenges, which I didn't mention earlier. Part of the problem we have with cancer survivors is that a lot of them, the symptoms get so decompensated that they end up at an emergency room. And as you know, that's not good care for them. And the same thing with hospitalizations.
Mm-hmm.
So we're getting signals that engaging in the system has an impact on these very hard clinical outcomes. So we're very pleased to see that.
Mm-hmm.
Now we're conducting the analysis looking at, I think what you were getting at, the relative contributions of depression, is it the fatigue? Mm-hmm. What is it that's getting these patients into the emergency room?
And what I find fascinating is that now you've been working on this tool for some time, and you launched it just before COVID.
Yeah.
Right?
Yeah.
And so tell me about the impact of COVID on your ability to launch the tool. Was it fortuitous? Did it end up playing to your advantage? And how's that impacted data collection and everything else, and analysis?
It's a bit of a silver lining if you think about it, because we as a society were forced, even if you're not a high user of technology, you had no other choice but to use technology, do your COVID screening before you came in for a visit.
Right.
So I would say that it helped. It helped us promote the concept and the culture of remote monitoring to help optimize your clinical encounter.
That's great. So how do you envision continuing to refine this particular tool and to make it even more applicable?
Sure, Dean Ford. So the next step here, so we're moving more towards, so let me just talk about a little bit about research embedded in that. So pragmatic trials are becoming more and more popular within the behavioral sciences and behavioral medicine, meaning that rather than having a very controlled RCT within our lab, we want to move those trials
randomized clinical trial
to the
controlled
clinic,
trial,
to the clinic, where it's more relevant. And for me, that's very satisfying, because of seeing all this work from decades that we've done in very controlled environments taken to the clinic. So the idea is that we're going to be able to do risk stratification for our patients, start looking at patterns of depression, patterns of fatigue, and based on that, start releasing technology-based modules and interventions to help these patients. So one example that goes back to culture is, for fatigue, the recommendation is physical activity. But many people say, oh no, I'm too fatigued to exercise, or I've had cancer, I shouldn't be active. So we want to address
and
that
that's
also.
When you need to be active.
Exactly.
That's a paradigm shift.
Yeah.
And that's fantastic. And is there going to be some way of nudging The patient say, "Get off the chair. Get off in front of the television."
Then a very important part is the provider facing part of this, because we also have to work with providers and make sure that they're promoting this, because patients listen to their doctors. So if the doctor says this is good for you, they're going to do it.
So you must feel really good that your work, this particular work, was it caught the attention of the White House.
Yeah.
Tell me about that.
Yeah, and the best part of that is that it was a trainee of mine, Patricia Moreno, who's faculty here.
Wow.
I recruited her from Northwestern to come here to Miami. So Patricia was recognized by Joe Biden for her efforts in working with the Latino community in cancer, and particularly focusing on the unmet needs of the cancer community, which in some ways also has promoted this cohort study that we're doing right now, because it just highlighted the fact that this community remains underserved and understudied. So it made it to the White House. I can't tell you exactly how, but they reached out to us. We were at a conference in San Antonio, and Joe Biden was planning a visit to the Mace Cancer Center, and they specifically selected Dr. Moreno to meet with her. And it just, you can imagine, a trainee of mine, it just made me so proud.
It must be quite gratifying to know that your work, the people you've trained, have reached the highest level of the U.S. government, and as something that ultimately will hopefully impact policy.
Absolutely.
So this is great. So Dr. Penedo, it's just been wonderful talking to you and learning about your pioneering work in cancer survivorship. Thank you for the innovative approaches that you have brought to the study, and I'm just thrilled to imagine what's going to happen with the data that you're generating. So,
well, thank you so much. We wouldn't be able to do this work without your support and the amazing colleagues we have here. So thank you.
Definitely look forward to learning more about your findings, and then watching the publications go out, and more importantly, see your work translated into policy to impact the quality of life for not just Latinx patients, but everyone altogether, because this is quite significant.
Absolutely.
Dr. Penedo, thank you so much once again for joining us this morning, and for all of our listeners. This is Henri Ford for Inside Your Miami Medicine. Look forward to joining you again at another time. Thank you.